Okay, good morning. This is Lisa Joy Klein. I am the clinical practice leader of the CCU, and I am reviewing neuro emergencies in the CCU for our monthly enrichment. And I'm about to share my screen here. Okay, here we go. Bethany Young, the CNS on the neuro ICU unit, helped me make this presentation with all of these things that you would want to know. So just to review, HUP is a comprehensive stroke center. That means that we are able to care for complex patients. We can offer endovascular treatments like TPA and endovascular lysis, and we have the trained specialists in that area that we need. One of the most important things that I'm presenting today is the resource from where you need to go if you have an emergency and you need help. And it's basically once you go to SharePoint, if you type CSC, it opens the CSC SharePoint for Penn Medicine that has on it all of the required paperwork that you would need, such as the TPA paper flow sheet, a post-thrombectomy flow sheet, and any information you would want to know about being a comprehensive stroke center. So please don't forget that that is available to us. So what is a stroke? Basically, the definition is a sudden focal neurological deficit due to a vascular cause. There are three types of strokes: ischemic, intracerebral hemorrhage, subarachnoid hemorrhage. So obviously think of it like pipes. Your pipes are either blocked or they've busted. So you have clot or you're bleeding. Some of the signs of symptoms for stroke, this can be a little tricky. I'm just going to review them. Weakness or numbness in the face, arm, leg, or one side of the body. The inability to speak, aphasia, slurred speech, dysarthria, visual field cuts, double vision, clumsiness, ataxia, just like a loss of coordination, dizziness, vertigo, a sudden decrease in level of consciousness, or they call the thunderclap headache or the worst headache of your life, which sometimes you'll see in a note as WHOL. Now, in the CCU, from my personal experience, and I'm sure all of yours, sometimes we're not sure if someone's having a stroke because some of these symptoms can mimic other etiologies, such as a seizure or having post-ictal paralysis after a seizure, structural lesions such as tumor, abscess, subdural hematoma, encephalitis, any metabolic derangements, including hypoglycemia, which is something that we do commonly see. Migraines, complex migraines can have a lot of the similar signs and symptoms, or psychiatric disease. So if you are not sure if someone is having a stroke, it is the best thing to do is just to consider it a risk of stroke and call a stroke alert. So what do I do now? I'm the nurse and I notice that my patient is having a decreased level of consciousness or numbness or tingling or a visual field cut, some neurologic change that I'm worried could fall into the bucket of being one of the kind of strokes. So you're going to call a stroke alert. There's a lot of focus out there in society, in a lot of organizations about stroke alerts coming from the outside, and we have a pretty good regimen for when someone comes in from the outside of the hospital. They are coming to a stroke center because there's a suspect of a stroke and there's a very specific chain of events that will occur. What we really want to focus on in this talk is in-house stroke alerts. So when you have a patient who's already admitted displaying some signs of a neurological change and what you do as far as being inside as an inpatient. So basically, you're going to call the operator and activate an in-house stroke alert. The information that you want to give the operator is the patient's name and room number and a number that they can call the provider. That operator will send out a stroke alert and connect the provider whose number you've given to the stroke fellow who will contact the provider. You will very shortly after have a neuro resident responding in person to you, probably walking down with you to CT scan while they're assessing the patient. So you're notifying the stroke alert, you're calling the provider to notify them, and then as a nurse, you want to prepare for the next steps. Things you should anticipate are a head CT, which usually in the same suite, you'll have a CTA and CT perfusion study. So you want to make sure that you have good access. The best access for this is a peripheral in the right upper extremity that's 20 gauge or greater. The other very helpful thing to know is the last known normal time, not the time of the onset of the symptoms that you're seeing, but the last known normal. So if the last time you were in that patient's room was an hour ago, then that's the last known normal, even though you're just discovering these signs and symptoms. Okay, so we talked about this. If you don't have a current IV access, the best thing to do is put a peripheral in the right upper extremity. Labs to anticipate are glucose, coags, BMP, CBC, tropes. Head of the bed should be 30 degrees or less, only if clinically appropriate. Obviously, we don't want to put patients at some other kind of risk for aspiration. You're going to go to your ABCs, okay? Monitor airway, breathing, circulation, and vital signs while you wait for the stroke team to arrive. The information that is helpful for you to establish is a basic neurologic assessment, which basically is the level of consciousness, like what's your name? Do you know where you're at? Where are you? Can you open and close your eyes? Can you squeeze your hands, both hands? Can you move both feet? So, and then are they responsive? Are they alert? Do they respond to stimulation? What kind of stimulation does it take for them to respond? And then the strengths of their arms and legs. That is the absolute bare bones basic information that's very helpful as far as your neurologic assessment. There's some patient history also that's helpful besides last known normal, which again we discussed was when you were absolutely certain the patient was at their baseline. What were they doing at the time of the onset of symptoms? What was the course of it? Was it sudden? Was it gradual? Did these things seem to fluctuate going back and forth? Any associated symptoms, headache, vomiting, photophobia, fevers, any relevant medical history. Why are they hospitalized? Have they had recent surgery? Are they anticoagulated? All of these are going to give clues to the team as what's going on so they can basically predict this is more likely a thrombotic stroke or this is more likely a hemorrhage. So your nursing assessment. We talked about the basic nursing assessment that you have to do as far as the basic neurological assessment, basically their level of consciousness, how they're responding to stimulation, their level of orientation, and then there's their motor strength, gross motor strength, upper extremities, lower extremities. As we all know, there is a much deeper neurological assessment that can be done. That is actually going to be done by the neuro team. Not that it's not helpful. If you know what you're doing and you're going to keep going, you're able to do this more in-depth cranial nerve exam, fine, do it. But what's important for you to establish is what we already discussed. So flashback to school is your cranial nerves, and you may or may not have some kind of mnemonic that you developed, whether it be clean and family oriented or dirty. I've heard there are numerous ones, but something about neurologic insults, that why it's important to be able to do that is because neurologic insults have location driven symptoms. So if you're having a symptom like all of a sudden you cannot move your tongue, then you know that you're probably having some kind of insult to the glossopharyngeal cranial nerve, and you know approximately where that's located in the brain. You also know what are the surrounding structures and what you can anticipate might also be affected. So that's the reason why location is important. And remember, if you see a focal deficit, that's very important to tell the provider because it can give them clues to what's going on. So NIH stroke scale, you can actually get certified in the NIH stroke scale if you go on the American Heart Association website. There is, and I believe it's free to be certified in it. But this is the basic stroke scale. So what's important to know about the stroke scale is normal as you and me is 0. So this can get tricky because on certain documentation at Penn Medicine and at other places, the way that they're going to ask you to score things as far as muscle strength, 0 would be nothing. So 4 or something would be normal. So just the point of this slide being read the directions, okay? Make sure you know what you're scoring someone. Level of consciousness, as you can see here, is if you're giving someone a 0, it means they're normal. So that might be a little bit counterintuitive to what we normally do. If you give somebody a level of consciousness of 0 in another assessment tool, it could mean that they're totally obtunded. Just read the directions. And this is especially on the flow sheet, like for TPA, it is reversed. So just make sure you read the directions before you score something. This picture looks crazy. And the reason that I put this on is just I wanted to share with you, this is the way that as a nurse practitioner, we learn to do cranial nerves. And it seems like a really weird picture, but sometimes this will be more memorable to people. I don't know, that's kind of weird, but like one thing I remember is the 8, like 8s are the ears because they kind of look like figure 8s. So like the 8th cranial nerve is your vestibular cochlear nerve, so hearing and proprioception. And I just wanted to go through it as a reminder in case anybody wanted to relive their school days. But a very popular mnemonic to remember the 12 cranial nerves is on old Olympus towering top, a Finn and German viewed some hops. So just to review, olfactory is 1, and you can see this crazy lady has a 1 in place of her nose, so it's smell, and you can test that using an alcohol pad if you need to in a pinch. The 2s are the eyes, and that's vision, like visual acuity, like how many fingers am I holding up. And then 3, you can see are the eyelashes, and 4 are the eyelashes, and 6 in the corner of the eyes. 3, 4, and 6 are all about eye movement. So basically when you say follow my finger, and you can either do like the X or you can do an H figure. If they can go in all these directions, they're clear for cranial nerves 3, 2, and 4. 5 is trigeminal, which a lot of us are familiar with trigeminal neuralgia, which can be severe pain in the scalp down to the jaw area. So generally it's just touching the face and seeing like, does that feel normal? Just does everything here feel normal? And also the muscles of mastication, like can you make your jaw tight or not? You can feel somebody doing that if you just put your hands here. Eyebrows are 7. You can see crazy lady has crazy 7 eyebrows, and that's just basically telling somebody bring your eyebrows up, act surprised, and sometimes even can you scrunch your eyebrows in, and then you can furthermore just put your hands on there and say try to hold it like that and try to kind of fight them with it, and that's a really good test of their strength of their 7th cranial nerves. 8, as I said, is hearing and proprioception, where her ears are. 9 and 10 in the mouth, you can see the 9 and the 10, that is the glossopharyngeal and the vagus nerve. So taste, speech, swallow, which is basically you would just ask somebody to speak or say something and maybe swallow. 11 is the spinal accessory nerves, and basically is shoulder and head movement. So you can just put your hands to the side of their face and ask them to push, give them a little bit of tension against their face and have them push against your hand on both directions. Same with shrugging the shoulders, ask them to shrug their shoulders up and down, just give them a little bit of force so you can actually feel how the muscle grating. And then 12 is the movement of the tongue. Move your tongue left, move your tongue right. You can even take a tongue depressor and put it against the tongue and make sure that it's nice and strong. So that is, just so you know, that is a very advanced, that's like an NP kind of overview, but I wanted to share that with everyone in case you really feel like you want to do a more detailed exam. But again, for stroke alert, keep it simple, talking about upper extremity strength, lower extremity strength. Do you know where you are? Level of consciousness, how much stimulation it takes for someone to respond. Okay, so you're going down to CT. Why are you going down to CT? Because you are trying to distinguish ischemic from hemorrhagic stroke. And even though you may have a good clue based on the history and what's happened through the day that it's one or the other, this is a diagnostic test. A CT can tell you whether there is blood, whether the blood is old or new. Then they may do a CT angiogram, which is looking for large vessel occlusions, and that is why they may need the right forearm peripheral IV, 20 or larger. And then the CT perfusion looks at the ratio of brain matter, your core to penumbra. Basically, This is basically saying if the stroke has happened a long time ago, not long time, hours and hours ago, and there's already been damage that is quite permanent and not reversible, that's what a CT perfusion will be able to tell you. It'll tell you the mismatch of what is salvageable and what is already dead. So if you may think, well, why don't we just reperfuse everyone? It doesn't matter. It does matter, because if you reperfuse someone who has a high ratio of dead tissue, you actually are at a higher risk of converting that person to a hemorrhagic stroke. So what you want is the core to be small, and the penumbra to be large. The penumbra is what's subject to damage. The core is what's dead. And time is key, obviously. Some people have a stroke, and this happens very quickly. The amount of dead tissue they have will happen very quickly. Other people, it happens very slowly. It is very unpredictable, and that's why these 3 tests are very important, and these will be done immediately when you call a stroke alert and bring someone down to the CT scanner. So therefore, prior to CT scan, you're not giving aspirin, you're not giving heparin, you're not giving TPA, and you're not giving blood pressure meds unless your MAP is over 140. So it's definitely allowing some hypertension, but not too much. So in the meantime, sorry to beat a dead horse, you're still going to do the same thing you always do. You're going to assess your ABCs. You're going to lay patient back for cerebral perfusion. Permissive hypertension, for TPA, your blood pressures have to be under 185 over 110 before starting the therapy. You're going to start documenting on your stroke or TIA flow sheet, which is found on that SharePoint site. You're going to do an aspiration risk screening and probably not give them anything to eat or drink in that moment. And then you're going to add the stroke care plan and education. So here's what we want to do. We want to restore cerebral blood flow. We want to prevent recurrent thrombosis, minimize the damage, and then supportive care. All right, so TPA, eligibility. Obviously, the clinical diagnosis of ischemic stroke within 4.5 hours of onset. It can't have any recent trauma, surgery, bleeding, not rapidly improving symptoms, because that would mean that it's probably a reversible cause or a TIA. No seizure at onset, no severe headaches. Again, these are all things that would make you think hemorrhage. Blood pressures need to be under 185 or over 110. The CT has to have no signs of intracranial hemorrhage or major early infarct signs. The glucose should be normal, platelets should be normal, and they should not already be anticoagulated. Something that comes up sometimes in the CCU is most of our patients are anticoagulated, especially the ones that are high risk for stroke, like VAD patients. So a lot of times there's a thought that this person is already heparinized and already therapeutic, and that they're not going to be eligible for TPA. But please do not delay calling the stroke alert and getting them down to CT. They still could be eligible for a thrombectomy. So don't just think that, oh, this person's never going to get an intervention, so I can just take my time. That's absolutely not the case. If someone is heparinized and anticoagulated, you can still do a thrombectomy in Neuro IR up to 24 hours after the onset of signs and symptoms, so don't delay. In the TPA nursing policy, there's a link to all the exclusions to see if a patient is TPA eligible or not. If the patient is TPA eligible, the pharmacist will mix up the bolus of TPA, and the stroke team will administer the TPA bolus. The nurse will monitor the patient after the TPA bolus for bleeding and angioedema. The nurse will document vital signs, the neurologic assessment on the TPA flow sheet. Exclusion criteria, again, is listed here. It's in the policy. It's on the formulary for TPA as well. This is a little screenshot of the stroke TPA flow sheet, so you can see it's a little small, but again, it is on the SharePoint site. So just for some reminders, if you are having to be the nurse who's administering TPA, you're going to get a dedicated IV that's established just for the TPA. You're going to keep the blood pressure. So for initiation of TPA, it has to be under 1 185 over 110, but for some reason that number is a little different from maintenance. So throughout the TPA infusion, your blood pressure has to be 180 over 105 or less for the next 24 hours. And usually these patients are often maintained on some kind of medication in order to keep the blood pressure aggressively below that. No antiplatelets or anticoagulation for 24 hours. You'll get a CT scan obviously right away, but then again, 24 hours post-infusion before any antithrombotic can be resumed to make sure you haven't converted or started bleeding. You're going to avoid invasive procedures for 24 hours because you are at high risk for bleeding, and you'll be monitored in the intensive care unit. Again, just to hit this home, the pre-treatment blood pressure guidelines are a little different than the duration. So pre-treatment has to be under 185 to 110 prior to TPA, and then you would do whatever you needed to do to lower the blood pressure, but most likely it will be labetalol or nicardipine. During and after TPA, you're going to monitor vital signs and neurochecks per the schedule, which is right on the vital signs on the flow sheet. But just to remind everyone, it's every 15 minutes for 2 hours, every 30 minutes for 6 hours, every hour for 16 hours. And you're going to keep that blood pressure low. The supportive care for ischemic stroke, again, is just ABCs, normal saline, supine position, normoglycemia, normothermia, aspirin, DVT prophylaxis, and permissive hypertension. There's just a couple slides on intercerebral hemorrhage, which is actually much less common. If you assess neurodeterioration that has an acute change in level of consciousness, severe headache, nausea, vomiting, and acute increase in blood pressure, you're going to more suspect an intercerebral hemorrhage. Again, to take you back to nursing school days, don't forget your Monroe-Kelly doctrine, where an increase in the volume of any one of the 3 components of the brain, blood, or CSF, will be at the expense of the other 2 until it can no longer autoregulate. So that's increased intracranial pressure. Signs of increased intracranial pressure is the change in level of consciousness. In the eyes, you'll see pupillary changes. You could see posturing, decreased motor function, headaches, seizures, change in vital signs that is consistent with Cushing's triad, which is basically increased blood pressures, decreased pulse pressure, and altered respiratory pattern, and vomiting or changes in speech. So, increased blood pressures, decreased pulse, bradycardia, and respirations. Now, if I think there's a bleed, do I have to do anything different? The only other things that are going to be different about your stroke alert is you're going to keep normotensive. You're going to also anticipate that you may need to call blood bank because you will be getting some cryoprecipitate, thawed plasma, and platelets. You can just let them know that you're calling a stroke alert, that you're pretty sure it's hemorrhagic, and to just stand by for the orders. Once they get the orders in, obviously you'll be delivered these blood products. You would consider reversing or stopping anticoagulation, and in the CCU, this is often a VAD patient, so make sure you are consulting with neuro and with the VAD team to make that decision all together collaboratively, and then the team can consider neurosurgical evacuation if that's possible. There is a PEN pathway and a formulary guideline for management of acute intercerebral hemorrhage, and also management of hemorrhagic transformation after TPA. So if you have time, check out the PEN pathway on those, and I have a link to it at the end of this talk, which is right here. So feel free to take a look. I'm hoping that that's covered a lot of the basics or some review for you on neurological emergencies in the CCU. So that's my presentation. I'll just open it up. We have a few minutes for questions. If there's a question that I can't specifically answer, Bethany was unable to make it for this talk, although she did help me put it together, and she is willing to answer any questions that we may have. So I'm going to stop sharing now and see if you guys have any specific questions. I will take notes and we can get them answered.
I have a question.
Yes.
So Do you have a preferred like flow of how we would call a stroke alert here in the CCU? Like, should I just go right at it, or should I grab the resident first and let them do it? How do you feel?
So usually in the CCU, it's as much as turning around and telling, they're usually present to say, I think we need to call a stroke alert, or I'm calling a stroke alert. If there's a delay in that, the provider's not there and you're trying to contact them, I would not delay the stroke alert, because the worst thing that can happen is everything is normal, right? So if the two can happen fairly close together, or you can say to the provider, I'm a little concerned here, we should call a stroke alert, can you call them, or I'm going to call them, and those two things happen very close together, then it doesn't really matter. But if there is a delay and you can't reach the provider, just call the stroke alert. But know the provider's name and number so the stroke fellow can contact the provider right away. If anything comes up in the meantime, feel free to email me and I will address any of these concerns or questions. But I hope that has been a helpful refresher.
Wonderful job, LJ. Thank you.
So thank you so much.
Well done.
I will send it out to the group.